and welcome to this evening's Fireside Chat. My name is Dr. Yuri, and I'll be the moderator for this session. This is going to be a 172 Fireside Chat in the series, and we do have an interesting topic this evening on protein energy wasting in CKD, and we are going to look at case-based insights. The guest lecturer or guest speaker for this evening is Dr. Sumida. If I get his name right, Dr. Keiichi Sumida, and is an associate professor in the Division of Nephrology, the Department of Medicine at the University of Tennessee Health Science Center. He is currently the chair of International Society of Renal Nutrition and Metabolism, ISRNM, Patient Resources Committee, and a member of the ISRNM Education and Publication Committees. He serves as an associate professor, associate editor for Nephron, an editorial board, a member of Diabetes Care, Journal of the American Society of Nephrology, Clinical Journal of the American Society of Nephrology, that is CJASN, and Kidney 360. His research interests are centered on epidemiology and outcomes, gut-kidney-heart axis, bone and mineral disorders, detecting modifiable non-traditional risk factors, and identifying optimal care in chronic kidney disease through clinical studies. So I'm looking forward to a very enlightening session, and I'd like to hand it over to Dr. Keiichi. Over to you.
Thank you very much for your very kind introduction. Hello, everyone. My name is Keiichi Sumida, again from the University of Tennessee Health Science Center in Memphis, Tennessee. First of all, I'd like to thank the organizers for this wonderful opportunity to give a talk about protein energy wasting in CKD, case-based insight. So I have nothing to disclose concerning this presentation. So the objectives for today are to provide an overview of protein energy wasting, or PW, in CKD, including the definition, diagnosis, and assessment of PW, and to review the prevalence, causes, and consequences of PW in CKD, and to discuss therapeutic strategies for PW in CKD, with a particular focus on optimization of dietary nutrient intake recommended by the current clinical practice guideline. This topic is actually very broad, and I'm not be able to cover everything, like detailed biological mechanisms and various pharmacological interventions available for to treat PW. But I hope you can at least get a better idea of what the PW is and why it is important in patients with CKD. Okay, before moving on to the main topics, I'd like to first have our case presentation and give you a few questions. So here, Mr. S is a 44-year-old male who has been undergoing maintenance hemodialysis for 6 years, was admitted to the hospital with pneumonia. Besides his symptoms related to pneumonia, he describes persistent fatigue, loss of appetite, and unintentional weight loss of 10 pounds over the past 3 months. His relevant clinical findings include body weight of 140 pounds, BMI of 19.5, and his serum albumin of 2.9 grams per deciliter. His dietary intake is reported to be poor, with an inadequate intake of protein of less 0.4 grams per kilogram per day, and calories of 15 kilocalories per kilogram per day, confirmed by his dietitian. So here the questions are, based on Mr. S' clinical presentation, what is the most likely diagnosis? And what criteria are used to diagnose his condition? And how would you further assess this condition? And another question is, what specific dietary recommendations would you make to address Mr. S' condition, considering his current CKD status? And what other interventions would you consider for the management of this condition? Okay, with these questions in mind, so now I'm talking about the definition, diagnosis, and assessment of PW in CKD. What is protein energy wasting, or PW, in CKD? In contrast to the term malnutrition or undernutrition, that is a consequence of an insufficient nutrient intake and primarily reflects a loss of fat mass. The term protein energy wasting, or PW, which is previously referred to as uremic malnutrition or protein energy malnutrition, is the state of undernutrition that could result from a complex interplay of decreased nutrient intake and increased catabolism due to various causes, which I'll explain later. And this condition reflects a loss of fat mass and body protein stores. That means the status of decreased energy fuels in the body. And this term was defined by an expert panel of the International Society of Renal Nutrition and Metabolism, or ISRNM, in 2008. And the clinical diagnosis of PW in CKD is made based primarily on these diagnostic criteria, again, proposed by the ISRNM. And as you can see on the left side, diagnosis include 4 different aspects of nutritional parameters, including serum chemistry, body mass, muscle mass, and dietary intake. And you need to meet at least 1 criterion in 3 out of the 4 categories. Here, it is important to note that sensitivity to diagnose PW using these criteria is low, unfortunately, because of its very strict criteria. So in clinical practice and even in research studies, several other tools can be used for the screening and assessment of PW in patients with CKD. But importantly, there is no single measurement tool that provides a complete assessment of nutritional status, which means that comprehensive nutritional assessment should always be made in combination with various assessment tools. And in this context, the Kidney Disease Outcomes and Quality Initiative, or KDOQI, recently updated the clinical practice guideline for nutrition in CKD. And one of the major focuses of this guideline is on the nutritional assessment. Consistent with the diagnostic criteria for PW, here you see 3 different aspects of nutritional assessment, including serum chemistry, dietary intake, and body weight and composition. Regarding the serum chemistry, it is important to keep in mind that these markers are often influenced by non-nutritional factors such as proteinuria, inflammation, and volume status. And hence, the results of these markers should always be interpreted with caution and as part of a more comprehensive and inclusive nutritional evaluation. For example, serum albumin has been suggested to be a sensitive method for identifying patients at risk for PW, but the guidelines stress that serum albumin alone cannot be used as a reliable indicator of PW in CKD. And for dietary intake, we should incorporate dietitian interview-assisted food records and questionnaires. And for body weight and composition, we have a variety of markers, including not only BMI and body weight, but also mid-arm circumference, skin fold thickness, hand grip strength, bioimpedance analysis, DEXA, and CT or MRI, which usually requires technical devices and therefore may not be commonly used in daily clinical practice. And we can assess the nutritional status using these assessment tools individually, but there are also composite nutritional indices that can be used to assess nutritional status and also to detect PW in CKD. And these include 7-point Subjective Global Assessment, or SGA, and Malnutrition Inflammation Score, or MIS. And the KDOQI guideline recommends the 7-point Subjective Global Assessment as a valid and reliable tool for assessing nutritional status in patients on dialysis, and suggests the use of Malnutrition Inflammation Score for nutritional assessment in patients on hemodialysis and post-transplantation. Importantly, there is limited evidence to suggest the use of one tool over the other for identifying patients at risk of PW. And here, just to take a closer look at 7-point SGA, you ask questions about patient history, including weight loss, reduced dietary intake, GI function, and functional capacity. Then you perform their physical exam related to nutritional status and report whether or not there is a muscle wasting, subcutaneous fat wasting, edema, and ascites. And clinical judgment is based on the score ranging from 1 to 7, where 6 to 7 is well nourished, 3 to 5 is mildly or moderately malnourished, and 1 to 2 is severely malnourished. And on the other hand, malnutrition inflammation score, or MIS, is essentially similar to SGA, but it's a more comprehensive scoring system that incorporates the component of the SGA and some additional parameters, such as serum albumin levels and BMI, to capture inflammatory aspects. Okay, then how often do we need to assess nutritional status? As shown here, the guidelines suggest that a registered dietitian nutritionist or an international equivalent conduct a comprehensive nutrition assessment at least within the first 90 days of starting dialysis annually, or when indicated by nutrition screening or provider referral. How about their assessment of body weight and body composition? As shown here, the suggested frequency depends on their stages of CKD, and it is at least every 6 months in patients with CKD stage 1 to 3, at least every 3 months in CKD stages 4 to 5, or post-transplantation, and at least monthly in patients receiving maintenance hemodialysis and peritoneal dialysis. Okay, now switching gears a little bit, and I'm talking about the prevalence, causes, and the consequences of PW in CKD. Okay, on the top of this slide, you have various stages of CKD, and then on the bottom, you have infographic that shows how appetite gradually changes as the CKD progresses and ultimately reaches ESKD. And when we think about some of the criteria of initiating dialysis, anorexia is something that we mention as a potential symptom of remia, which could be used to initiate dialysis. And what I'm showing here is the US prevalence of CKD. And then what I'm showing here is the estimated prevalence of PW across various stages of CKD. And as you can see, the prevalence varies widely in patients with non-dialysis dependent CKD, and it becomes extremely high in patients on dialysis, reaching up to 75%. And this trend is essentially mirroring the decline in appetite as kidney function declines. Regarding the worldwide prevalence of PW, the International Society of Renal Nutrition and Metabolism conducted a systematic review and meta-analysis several years ago, and reported that the worldwide prevalence of PW was estimated to be ranging from 11% to 54% in patients with non-dialysis dependent CKD, and from 28% to 54% as an interquartile range in patients on dialysis. And as shown in the white areas in this global map, data are still lacking in several countries and regions. But even after the publication of this meta-analysis, some new data are coming out of a few countries, such as Tanzania, where a similarly high prevalence of PW was reported among dialysis patients. Then why is PW so common in patients with CKD? There are a large number of causes and complex pathophysiological interactions that contribute to the development of PW in CKD. And as shown here, this condition occurs not just because people are not eating well or not exercising enough, but also due to several other causes, such as volume overload, oxidative stress, carbonyl stress, inflammatory cytokines, acidosis, comorbid conditions, endocrine disorders, nutrient loss during dialysis, other dialysis treatment-related factors, and uremic toxins. And in addition to these known causative factors, here I want to note that the gut dysbiosis has also been recently recognized as one of the risk factors for PW in patients with CKD. And I will have a little bit more to say about this later. Among the causes of PW, one of the key considerations in patients on dialysis is the nutrient loss during dialysis treatment. As many of you know, whether this is hemodialysis, hemofiltration, continuous hemofiltration, or peritoneal dialysis, there are an incremental loss of amino acids and proteins throughout the process of dialysis. For example, during each hemodialysis session, 6 to 12 grams of amino acids and 0.5 to 15 grams of protein are reported to be lost. And when it comes to the pathophysiology of PW in CKD, there are a few general considerations that merit special attention. First, the factors contributing to PW may vary depending on the event that occurs during the evolution of the disease. Second, given the varying comorbid conditions associated with CKD, mechanisms that initiated PW may not be operative at the later stages of CKD, where other potential mechanisms may come into play. Third, there are inherent redundancies in molecular, cellular, and biochemical events that regulate protein and energy metabolism, which in turn make it difficult to disentangle the pathophysiological mechanisms underlying the PW in CKD. That being said, accumulating scientific data have now provided a mechanistic framework for understanding the relationship between CKD and PEW. And as shown here, PW in CKD is a result of the combination of phenomena leading to a decreased nutrient intake and a concomitant development of a homeostatic milieu that favors protein catabolism or proteolysis. And here you see various issues such as nutritional restriction and anorexia through increased leptin and inflammatory cytokines and increased glucocorticoid levels. And we have these other well-known metabolic derangements such as acidemia, vitamin deficiency, altered glucose homeostasis, and insulin resistance, all of which leads to a protein breakdown or catabolic state. And here we have an additional set of arrows delineating complex and overlapping mechanisms that affect both sides. And also here, we have the gut dysbiosis as a novel mechanism that can lead to anorexia, mediated in part by microbiota-derived hormonal changes. And as a result, we see patients with PW who present with decreasing serum albumin, muscle mass, etc. over time. And I threw in here one slide about a recent cross-sectional study that suggested a possible involvement of the gut dysbiosis in PW in patients with ESKD. In this study, researchers compared the gut microbiota composition between hemodialysis patients with and without PW, and they showed that a striking difference in the composition of gut microbiota between these patients with a significant reduction in butylate-producing or beneficial bacteria in those with PW. Similarly, in a more recent longitudinal study of 57 hemodialysis patients, researchers looked at the association of gut microbiota composition with the development of PW, and they found that the lower relative abundance of actinobacteria and bifidobacteriaceae was associated with a higher risk of the development of PW. Obviously, further studies are needed to confirm the causality of the observed associations, but these findings suggest the potentially novel mechanistic link between gut dysbiosis and PW. Then, what about the consequences of PW in patients with CKD? Why should we care about this condition? As shown in the green boxes at the bottom of this figure, PW has been associated with several unwanted clinical conditions, including abnormalities of body composition markers and laboratory parameters such as low albumin and high CRP levels, atherosclerotic cardiovascular disease, lower quality of life, and higher risk of hospitalization, all of which eventually contribute to a higher risk of premature mortality in this population. And in fact, a number of epidemiological studies have consistently reported the association between PW and higher risk of mortality. Here, I'm showing the result from a prospective cohort of more than 1,000 hemodialysis patients examining the association of 7-point SGA of nutritional status with all-cause mortality. And as shown in the Kaplan-Meier curve on the right side, the study showed that PW, defined as a low SGA score, was significantly associated with a higher risk of mortality over the follow-up of 7 years. And in a more recent retrospective study of 661 CKD patients who transitioned to dialysis and had at least 2 24-hour urine creatinine measurements during the 3 years prior to dialysis transition, we examined the change in muscle mass as quantified by 24-hour urine creatinine and its association with all-cause mortality after dialysis transition. And as a result, we showed that more progressive loss of muscle mass was associated with a higher risk of all-cause mortality after dialysis transition. Here's another study looking at the association of dietary protein intake assessed by the urea kinetic-based protein nitrogen appearance with all-cause mortality in hemodialysis patients. And as shown here, the study showed that the low daily dietary protein intake was associated with a higher risk of all-cause mortality. Okay, now I'm moving on to the last topic about therapeutic strategies for PEW in CKD. Given the complex and multifactorial etiology of PEW, the treatment often requires a multidisciplinary, multifaceted, and individualized approach. And these include optimizing dietary nutrient intake through the nutrition counseling from a registered dietitian or nutrition professional, appropriate management of metabolic disturbances, such as metabolic acidosis, systemic inflammation, and hormonal deficiencies, and prescribing optimized diuretic regimens. If these standardized therapeutic measures are not very effective in alleviating the loss of protein and energy stores, additional strategies such as exercise and pharmacological interventions are usually considered. But as you know, among all these measures, the optimization of dietary nutrient intake or dietary modification is generally recommended as the first step therapeutic approach to PEW in CKD. And when we think about the optimization of dietary nutrient intake, there are two very important points that I want to stress. The first point is their collaboration, and the second point is their personalized therapeutic approach. And as stated in their Keiichi clinical practice guideline, it is important to keep in mind that the medical nutritional therapy should be prescribed in close collaboration between physician, dietitian, and other healthcare providers, which is ideally tailored to the individual's needs, nutritional status, and comorbid conditions. And this slide is a summary of recommended dietary intake of energy and protein, as well as some other key electrolytes. For example, for adults on dialysis, the guideline recommends energy intake of 25 to 35 kilocalorie per kilogram per day, and a protein intake of 1.0 to 1.2 gram per kilogram per day. Importantly, the calorie intake should be based on age, sex, level of physical activity, body composition, weight status goals, CKD stage, and concurrent illnesses or presence of inflammation. And here, the relatively high protein intake recommended to dialysis patients is because of their known protein losses in dialysis that I mentioned earlier, and also a greater protein catabolism from metabolic stress in this particular population. And if dietary counseling alone does not achieve sufficient energy and protein intake to meet nutritional requirements, the guidelines suggest a minimum of a 3-month trial of oral nutritional supplements, or ONS, to improve nutritional status. I'm not going into details about the types of ONS today, but there are several commercially available products, such as Ensure, that can be used for ONS. And if this ONS is inadequate to meet their patient's needs, enteral nutrition supplementation can also be considered. And this enteral route fails, then we can move on to their intradialytic parenteral nutrition or total parenteral nutrition. Okay, so regarding the effectiveness of nutritional support for PEW, currently a large body of evidence is supporting its beneficial effects in both advanced CKD patients and patients on maintenance dialysis. According to this review article that included randomized prospective control trials, the treatment of PEW with nutritional support was shown to be effective in increasing body weight, body fat, lean body mass, arm muscle circumference, and serum albumin and prealbumin levels. And in terms of the effect of nutritional support on hard clinical outcomes, such as mortality, evidence is still limited to non-trial clinical studies. For example, this retrospective propensity-matched cohort study of more than 2,000 hemodialysis patients with and without ONS The ONS prescription was associated with a 29% reduction in all-cause mortality. But the survival benefit of ONS in dialysis patients has not been borne out in clinical trials, so this needs to be tested in future clinical trials. Okay, here in the last slide of my presentation, I'm showing some implementation considerations for ONS that Keiichi mentions. In short, the guidelines suggest maximizing benefit by tailored prescription and based on patient preference and available resources, monitoring provision to increase total protein and energy intake, and using energy-dense and low electrolytes ONS to avoid fluid overload and electrolytes derangements. Okay, so back to the very first case presentation. Now I hope everyone can answer these two questions. So for the first question about the diagnosis and assessment, his unintentional weight loss, reduced serum albumin, and decreased protein and calorie intake meet 3 out of the 4 categories of PW, the definition of PW. So the most likely diagnosis for Mr. S is PW. And this condition can be assessed further using various nutritional assessment tools such as SGA and DEXA. Then in terms of the management, I would recommend increasing his protein intake to 1.0 to 1.2 gram per kilogram per day, and his caloric intake to 25 to 35 kilocalorie per kilogram per day, depending on the levels of his physical activity and concurrent illnesses or presence of inflammation. Oral nutritional supplements can also be considered. In addition, it is also important to appropriately manage metabolic disturbances and prescribe optimized dialytic regimens and recommend regular physical activities. And lastly, I would also carefully monitor his nutritional parameters during the follow-up and make sure to pay attention to potential complications associated with PW, such as cardiovascular disease and infection. Okay, now I will wrap up my presentation. PW is highly prevalent in patients with CKD due to multiple causes, and it is associated with adverse clinical outcomes. Comprehensive nutritional care includes screening of nutrition risk, assessment of nutritional status, and diagnosis of PW. Collaborative and personalized nutritional therapy is the key to improve nutritional and clinical outcomes in CKD patients with PW. Thank you very much for your kind attention, and I'd be happy to have any questions.
Thank you, Dr. Sumida. That was quite an enlightening presentation.
So much. Thank you. Thank you very much, Sumida. It is a wonderful session. A very complex topic, actually put very simply, and you covered the entire ground in a short period of time. You know, the ISRN classification, then the composite indices, both the SGA and the MIS, and the gut issues that are involved in the consequences of PW, then the increased risk and mortality associated with the issue, the progressive protein muscle loss, which causes mortality, the dietary protein decreased intake that again causes problems, and finally the therapeutic strategy is all the ONS, the enteral and the parenteral nutrition. Thank you very, very much. It was extremely well covered and exhaustive at the same time, everything put very simply. And the case, I appreciate the answers to the case in the end, very nicely presented, and thank you. That makes it much more interesting and more practically applicable. So we have this all videotaped, and we hope to put it online on on YouTube for everyone to see. And I think there were a lot of people who are interested here from the nutrition side and from the nephrology side, and extremely grateful for the time taken to come into East Africa, and despite your busy schedules and your prompt replies and getting you here has been such a pleasure, truly a pleasure. Thank you so much for coming in. But we hope we could get you again next year or sometime when you have time. I know you're very busy, just to give us a topic or two of which is dear to you as well. Thank you so much.
Thank you very much.